about acute kidney injury and chronic kidney disease. And I just want to set the objectives out before we get onto the actual theory of things and what things look like and things like that. So I really want to focus on actually recognizing that someone is potentially having a kidney injury, and also the subtle kind of signs and the symptoms that they may present with, which can further aid your diagnosis of an AKI and CKDA, and then managing them subsequently. We'll try and go through some urea and electrolytes interpretation. There'll be a question on those, so please pay attention so you can get the most out of this. And as always, I'll describe basic I'll describe the basics of the conditions and what causes them, risk factors, things like that, and then lastly management of the said conditions. So here, as you can see, that there's two pictures here of the urinary tract, and I think it's very important that we just discuss a little bit of anatomy before we get involved with the hardcore theory. So obviously the urinary tract is made up of two kidneys, two ureters, which are then connected to the bladder. And the function of the urinary system is to filter blood and then create urine as a waste byproduct. The kidney is responsible for filtering out a lot of liquid waste, also known as urea, and it's also responsible for keeping potassium, sodium, and water in balance as well. And yeah, as you can see from the images here, this is the renal cortex. This is the medulla, the renal pelvis, which is where the urine is collected and all the filtrate is collected, where it then passes through the pelvis, or the major pelvis, all the way down the ureters into the bladder to be excreted through the urethra. That's the basic anatomy done. So you might be thinking, what is AKI? So AKI is obviously acute kidney injury, and it is impaired renal function. And it basically refers to a rapid decrease in renal function over a few hours or even a few days, especially in kids. And there's many different ways of categorizing AKI. Most NICE and most of Europe tend to base it on 1.5 times increase in creatinine, with also 25% or more decline in EGFR as well, from the normal baseline. But you might find in different countries that there are different classifications. I'm mainly going to be using the KDIGO, which is the basis for a lot of European guidelines, especially the UK as well. And another thing that's not mentioned here, but another way of defining AKI is also low urine output. It's obviously a symptom and a sign, but you can actually define AKI with low urine output in the form of less than 0.5 mils per kilogram per hour as well. There's different types of AKI, or there's different etiologies, you could say, of AKI. So there's pre-renal causes, there's renal causes, which we'll go into a lot of detail about, and also post-renal causes as well. And just to put things into context and perspective, 15% of all hospital inpatients suffer from AKI, and out of those 15%, 25 to 30% will end up succumbing to kidney injuries, just because the body's just not able to process the sheer capacity of waste products and things like that. So what are the risk factors for AKI? So having chronic kidney disease unfortunately leaves you quite susceptible for having an acute kidney injury. Having organ failures, so this could be heart failure, this could be liver disease, and also liver failure can also precipitate AKI. And then chronic diseases such as diabetes, where the glomerulus is being impacted by the glycosylation and things like that. Having an AKI previously will also increase your risk. Unfortunately, if you're above the age of 65, that also predisposes you to having AKIs. Nephrotoxic drugs, which we'll also be discussing, also open you up, and radio contrast agents as well, such as iodine and other contrast. So how does AKI present? So, as I said before, AKI will usually present in the form of reduced urine output. So the way we define it is anything less than 0.5 mils per kilogram per hour is by definition acute kidney injury. There may also be edema around the body, and the edema around the body would be because of the kidneys not being able to filter, and subsequently you would have a big backlog of fluid, which would then start entering the interstitial space and other spaces as well. Arrhythmias. Arrhythmias are probably the most catastrophic presentation of acute AKI. So can anyone in the chat box, or perhaps Nisar, maybe you can open the chat box to some suggestions for what types of arrhythmias in particular might present in AKI?
The chat box should be open. If everyone wants to take a guess, they can just write the answer down.
And if you wouldn't mind just telling me as well, so just so I can see very clearly.
Yeah, of course, no worries.
Cheers.
So there's a couple of suggestions of VF or AF.
Yeah. Exactly. So AF, VF, pretty much anything, or any form of tachycardia and also bradycardia can be caused by AKI, and you're preliminarily dealing with the potassium aspect of electrolyte. So hyperkalemia or hypokalemia as well. In some cases of rare AKI can also precipitate all of these arrhythmias. Pericarditis and encephalopathy. So these are more features of the uremia, really. So obviously we know that the normal ranges of the uremia is between 2 and 7. So anything above 7 will or could potentially cause symptoms of uremia. Pericarditis is something that's usually caused by it, and then you'll have encephalopathy because of all the waste products going to the brain, and there'll also be quite a lot of pruritus as well. So as everyone knows, the mnemonic of dialysis, AEIOU, U is uremia. So in those cases, a lot of patients will need dialysis and they'll benefit greatly from it. So now we're on to the actual types of renal failure. So pre-renal failure is usually the most common of all of the AKIs, and it often leads to intrinsic AKI, which will be renal AKI if it's not corrected properly. And it's usually, or it can be provoked by volume loss. So by volume loss, this can be anything from diarrhea, vomiting, all the way to cutaneous burns and things like that, as well as hemorrhages. So that's volume loss. And then in terms of the decreased renal perfusion, no rewards for guessing this, but hypovolemia, or patients with heart failure or shock as well, can suffer from decreased renal perfusion causing the AKI. And there's several medications as well, which can unfortunately induce pre-renal AKI in those who are volume depleted anyway. So some of those drugs are ACE inhibitors, so basically drugs ending in pril, and also angiotensin receptor blockers, so ARBs, so we're talking sartans here. And there's also aminoglycosides, and also NSAIDs as well. So they usually tend to cause a lot of vasoconstriction, and when you already have hypoperfusion of the kidneys, they tend to exacerbate the condition more than anything. So can everyone see this? Can everyone see that this is a question? So Nisarg, this will be the first question. And if you wouldn't mind sharing the poll or telling me the majority of people's answers. So to read this out, so you are the on-call surgical junior doctor and have been asked to review an incredibly healthy 89-year-old female with low urinary output of 420 mils in the past 24 hours, despite having 2 liters of IV fluids administered over 8 hours. She was admitted with small bowel obstruction, and after examining her, you review her admission investigations, or the scans or the bloods, and also EPMA, which is the platform we use for prescribing medications and things. And you notice her potassium is 6 millimoles per liter, and she has a creatinine of 346 micromoles per liter. It appears she was given some medications in accident and emergency while she was being triaged to general surgery without her weight being calculated. So what medication could be causing the abnormal use and ease? And is there a possibility that all of these medications could potentially be damaging the kidney as well? So I'll leave that to all of you to try and answer. And Nisarg, if you wouldn't mind telling me the general consensus, that'd be great.
Yeah, basically, for some reason, there's an error coming up when I'm trying to load the polls. Can you give it a try and see if you can do it?
Let me see. Can you see it now?
Yeah, now it's working.
I mean, I'm more than happy to.
I'm not sure. It's saying that I'm not host, and it's saying that I'm not a host, so I can't do polls.
Can you do it now? Yeah, I think it's working now.
Yeah, perfect. There was also a question earlier regarding the mnemonic for dialysis, the AEIOU. I've said it in the chat, but if you want to maybe go over it quickly.
Basically, the indications for dialysis are, or the mnemonic for understanding the indications for dialysis are AIOU. And as you already know from me, the U is for uremia, and the AIOU are actually acidosis. E is electrolyte problems, so we're talking hyperkalemia here, potentially hypernatremia, and any electrolyte problem basically. I is so it could be anything from ethanol poisoning to paracetamol overdoses. Just quite rare usually, but it can still be. O is for overload or over fluid, and the U, as I said, is for uremia. And as I can see from the poll, a lot of people have correctly answered the gentamicin. Can anyone tell me why the gentamicin, perhaps, in the chat?
Really sorry, Stephen. I don't know. It's not letting me use the polls. I think you might have to take control of the polls, if that's all right.
Yeah, no worries. I'm now struggling to get rid of it.
Oh,
no, I got it. Yeah, I've got it.
So people are saying it's aminoglycosides are nephrotoxic.
Exactly. They're nephrotoxic, and they need to be calculated based on weight, age, sex, and height, as well as your creatinine as well. So this is something that happens quite often during hospitals, well, in hospitals rather, because there's a big impetus to try and treat potential sepsises and anything like that as rapidly as possible. And usually in most hospitals these days, anything abdominal will usually cause a bit of AMG, amoxicillin, metronidazole, and gentamicin to be prescribed. And it happens a lot that people do not weigh the patient, and they tend to go for a lot of prescribing errors in terms of the gentamicin. And also with gentamicin, you need to know that gentamicin can be given over 24 hours, 48 hours, and 72 hours as well in some cases, depending on the kidney function. So in this case, it is the gentamicin, but I just want to point out that the paracetamol, the oromorph, and the amoxicillin can also cause kidney problems. So paracetamol would probably be the third most potent the third most nephrotoxic choice in out of these four. Oromorph would be the second, but because the dose of the oromorph is quite low, I wouldn't really be too worried about the morphine causing any kidney damage. But this question will now lead you onto the renal causes of AKI. So as I've said, intrinsic AKI or renal causes of AKI can vary from structural injuries to tubular injuries, all the way to interstitial injuries. We've just got a question, so I'll just answer this as well. So just to confirm, it is the dosage of the gentamicin which makes it yes. In this case, 400 mg in an 89-year-old probably isn't the most smartest or the most safest option. If it was a lower dose, then for sure there wouldn't be any problems. But just because of the high dose, and it's likely it's been given as a stat dose as well, rather than over 24 hours or 48 hours, it can potentially become quite nephrotoxic, and it has in her case. Going back to this, so in terms of the structural injuries, we're talking about glomerulonephritis here, and in the glomerulonephritis, you obviously have nephritic causes, you have nephrotic causes as well. So the most common causes for renal injury in glomerulonephritis are usually rapidly progressive glomerulonephritis, RPGN. You'll probably learn by the end of this lecture. I like to use a lot of shortcuts and abbreviations for things, so I do apologize, but if you do struggle with them, please let me know and I'll explain them again. Good pasture syndrome. So good pasture syndrome is really a syndrome where you're having antibodies being formed against the glomerulus and the basement membrane as well. You have MPGN, which is membranous proliferative glomerulonephritis. You have PIGN, which is post-infective glomerulonephritis. So this can be usually after, staphylococcus infections, can be after any infection, basically. Also have VTE, so venous thromboembolism. So it doesn't just have to be a thrombus; it can be an emboli potentially from the left side of the heart. Can also be vasculitis as well. So with vasculitis, you obviously have you have large vessel disease, you have medium vessel disease and small vessel disease. For kidney diseases, usually it's usually medium vessel disease. So we're talking about granulomatosis with cholangitis. We're also going to be discussing things like eosinophilic granulomatosis with polyangiitis, also known as Churg-Strauss syndrome. And then potentially you could have microscopic polyangiitis as well. We also have DIC, so disseminated intravascular coagulation, because you will obviously have clumping up of thrombuses, and those thrombuses will then become microthrombi, and they could potentially enter the systemic circulation and clog up one of the kidneys. Hypertension, purely because of the destructive effect of scarring and things like that it has on the kidneys. And I think it's also wise to mention transplant rejection as well, because that will have a bit of an autoimmune cascade response for kidney function. Something that I've not mentioned here, which is also worth mentioning, is any sorts of trauma to the kidney region can also cause renal failure, obviously. That's structural injury. For tubular injuries, these will most commonly be affected by rhabdomyolysis, any kind of muscle death as well, tumor lysis syndrome in those people suffering with cancer, and then medications such as aminoglycosides, methotrexate, antivirals such as acyclovir, cisplatin, and also radiocontrast agents as well. So they can all do damage to the tubules, both ascending and descending. And then the last form of renal failure is interstitial injury. So interstitial injury can also once again be caused by medications, by infections, and also systemic diseases such as lupus, leukemia, and lymphoma, actually, for that matter, and also Sjogren's disease. That's kidney, or those are the renal causes for renal failure. Any questions after this? Before we move on to postrenal. I'll take that as none. I think it's fairly simple up until this point, to be honest. But if you do have any questions, please let me know, and I'll slow down, or I'll try and explain as well. Okay, so RPGN, so that's rapidly progressive glomerulonephritis, and MPGN is membranous proliferative glomerulonephritis, and PIGN is post-infective glomerulonephritis. That is, I find that's the easiest way of remembering what's nephritic and what's nephrotic, and just in general, what are the diseases, parts of those subtypes as well. Does that make sense? Awesome. So onto the postrenal side. So postrenal, quite, once again, fairly logical. It's mainly because of obstruction. So in terms of obstruction, we're talking about mechanical obstruction here. And the mechanical obstruction of the urinary collecting system, including the ureters, the bladder, urethra, etc., can be caused by any of these, the following causes here. So it could be stone disease, strictures, tumors. So both intraluminal, extraluminal, and also intramural as well. Can be due to clots, thromboses, and hematomas as well from both surgical procedures and also potential blood disorders. And there's also phimosis as well. So phimosis will be probably you'd like to think more to do with pediatric urology rather than adult nephrology and neurology, but it can sometimes affect adults just as much as children as well. So for ureteric obstruction, it's fairly simple. Stones, tumors, and fibrosis. One thing that I've not mentioned here, which I've just remembered, is the possibility of iatrogenic injury as well. So by iatrogenic, I mean we're causing the injury. So this is, believe it or not, it is quite common in general surgery, especially and in colorectal parts of general surgery, that there's ureteric injuries or the ureter is accidentally ligated, thinking it might be a vessel, and that can obviously cause postrenal failure as well. Bladder obstruction, in terms of tumors, it can be anything from prostate carcinoma to bladder tumors as well, obviously. Then you have BPH and neurogenic bladder as well, and clotting, as I said, which can sometimes be caused by surgical procedures like cystoscopy as well, and Botox injections into the bladder as well for uncontrolled, or for patients with bladder incontinence as well. So that's postrenal. So right now we've discussed what different types of AKI exist. We've talked a little bit about the symptoms. We've talked a little bit about the classification, I think. Or sorry, we haven't. We're going to be talking about it now. But I just want to ask you guys, how do we actually diagnose AKI? So once again, no surprises for guessing, but the way that we would diagnose an acute kidney injury beginning out to speak English today would be would mainly be due to urinary. So as you can see here, the bottle that we'd use for collecting the blood would be the gold top or the yellow top for the urinary, and the electrolytes here and the kind of parameters that we're dealing with are mainly to do with the sodium, potassium, chloride, bicarb, urea, and the creatinine, with specific focus on the sodium, potassium, and the urea and the creatinine as well. And so, as I said before, NICE guidelines recommend that they suggest that we can use a variety of different criteria to make an official diagnosis of AKI. So usually it's a creatinine rise of more than 1.5 in a short duration of time, usually within 48 hours, and it can also be decreased eGFR of 25% or more, and also urine output falling to less than 0.5 mils per kilogram per hour, as I mentioned earlier. So you would mainly diagnose AKI via blood test. However, if there's no identifiable cause for the deterioration, or someone is at risk of potential post-renal failure, they really ought to have a renal ultrasound within 24 hours just to rule out post-renal obstruction. And I'm not sure this is practiced a lot in hospitals, but in general, every patient that has got suspected AKI should have urinalysis as well, just to rule out any other pathology or etiology. So this is what we've been talking about. This is the AKI stages and you can see that there's three different stages. I'm not going to go into this as I've mentioned this lots of times now. It's another question as well. So how would you diagnose an AKI without previous use and use results? So it's an interesting question, because you wouldn't really be able to find out what the creatinine is doing if you didn't take blood. It's not normal for any AKI patient to be diagnosed with AKI without having blood. So it's imperative that they have bloods, that they're catheterized so we can measure their urine output. And in general, it goes hand in hand. If you do catheterize someone and you're noticing that they have got less than 0.5 mils per kilogram per hour being excreted, that they need the bloods to check their creatinine, because depending on the stages of the AKI, you may need to refer to a nephrologist as well, and there might be a potential siren of a dialysis indication needed as well if things do start worsening and patients deteriorate. So I hope I answered that question. So yeah, once again, 3 stages. The first stage is an increase of serum creatinine by 1.5 to 1.9 times on the baseline. Stage 2 is increased by 2 to 2.9 times, and 3 is 3 times. I think that's quite easy to remember. 3 for 3. Question as well. So if it's the first time without baseline bloods, i.e. just establishing base normal, for example, the patient is presenting clinically normal, yeah, you would. And you'd probably have to have a suspicion of AKI. For example, they have a fluctuating GS, their heart sounds, for example, could be muffled. You could have the classic sign of a friction type rub when you're listening to their chest. So all of those things considered, it would have to be a suspicion, but once again, you'd have to do the bloods, and if this person is presenting for the first time, you'd have to kind of have the first admissions blood as the baseline, and then go from there. Really, you'd have to treat them and then see if they improve, and if they don't, then you know that that's not the sign, if that makes any sense. No worries. So yeah, those are the 3 stages, and I hope all of you are paying attention and you're remembering this, because we're gonna have a question now to talk about the stages. So a 70-year-old gentleman presents to the surgical ESTEC, also same-day emergency care unit, with a presenting complaint of not being able to urinate for the last 9 hours despite having urge. He has a past medical history of type 2 diabetes and chronic back pain after a road traffic collision 50 years ago. His regular medications are metformin, ibuprofen, and he has adequate PPI cover for the ibuprofen, and he has no known drug allergies. His bloods today show that his sodium is within normal reference. His potassium is also within normal references ranges. Bicarb is all right. Urea is just mildly elevated, but the creatinine is 200 micromoles per liter, which is, as you can see, very, very elevated for normal reference ranges. So from all of the theory that we've discussed, what AKI stage would you guys put this gentleman in? I'll create this poll. So hopefully you can answer the poll now. It's been a 50-50 so far. last few seconds for everyone to have a guess. Right, so I think you can probably end the poll now. I think a lot of people have voted. So yeah, most people have voted for option 1, AKI 1. A lot of people have voted for AKI 2, and then a few people have also gone for AKI 3. I'm not going to go into the reasoning behind everyone else's decision, but it is AKI 1. So well done if you guessed it. Don't worry if you didn't. I'll now explain why it's AKI 1. So as I mentioned to you before in this previous slide, AKI 1 in the KDIGO classification is when our creatinine is between 1.5 to 1.9 times above baseline. And our urine output is less than 0.5 mils per kilogram per hour for more than 6 to 12 hours here. So all of the clues are in the history. So you would actually have a bit of a suspicion there for an AKI stage 1, especially. Yeah, I do apologize. You didn't have a baseline there, but I think when you've got such a barn door elevation in the creatinine, more often than not, you'd be able to diagnose the AKI. However, if you said to this patient that on discharge your GP will have to do a Urinary after 2 months or 3 months, and you noticed that it was falling, then it would probably be an AKI rather than a CKD situation as well. So I hope that makes sense. But to explain why it's AKI 1, well, firstly, it can't be AKI 4. So option 4 is completely off the table because it doesn't exist. And his urine output has well, he's not had any urine output basically. So that kind of leads you on to stage 1 on the urine output side of things. And because his creatinine is between 1.5 to nearly 2 times above the baseline, it would be in keeping with AKI stage 1. He has a risk factor in terms of his age as well. So he's 70 years old. He unfortunately has diabetes, and he also uses NSAIDs, the ibuprofen for his back pain. So that should also be should be ringing alarm bells inside your between your ears as well. AKI 2, just to go through it again, AKI 2 is when you have an increase in the serum creatinine between 2 to 2.9 from baseline, and the urine output is less than 0.5 mils per kilogram per hour for 12 hours or more. And then AKI 3 is creatinine more than 3 times, and the urine output is completely reduced, or if not, it is less than 0.3 mils per kilogram per hour for 24 hours or even longer. So this was an AKI interpretation. How do we, so now that we've discussed the different types of AKI, we know what AKI is, we know how to diagnose it. How do we manage it? Oh, sorry, just got another question. Did you mean the normal range and not patient's baseline? Yeah, so in a barn door case like that, you wouldn't really want to do a patient baseline. You would want to just get on with treating their AKI. You would try to get the GP to assess the baseline, and then it would probably be up to the GP to introduce a lot of medications to try and control that chronic kidney disease, if it is, or if not, it would be an AKI, obviously. And having the urge to urinate means it is a postrenal cause. Not always, because in the elderly, I haven't actually specified it very clearly there in that history, but as I'm unfortunately you might have seen with your own grandparents, they tend to not be the best with drinking water and keeping the fluids up. It's something that I see daily inside hospitals, and I'm sure you might have experienced it as well on placements and your interactions with your grandparents. So in this case, it would be dehydration as the cause of the AKI, but you can still have the urge without actually being able to urinate, because as you get older, you start to lose function of your bladder. So hopefully I've explained that. Or if I've not, I'm sorry. Perfect. So as I said, we've discussed what AKI is, and the only thing that we need to figure out is what to do when someone's suffering from an AKI and how do we manage it. So fluids are always a good shout, particularly if it's a pre-renal cause, right? Because they would be fluid depleted. In sepsis, they would have lots of vasoconstriction, so they would need a lot of fluid to try and overcome all of the vasoconstriction involved in it. But you have to be very, very careful with how many hours you prescribe fluids for, and also how many liters of fluids you prescribe, because in the elderly, in the young as well, and in general, anyone, it doesn't take that long for someone to start to feel overloaded and actually start becoming overloaded. So we should always tread with a lot of caution when we're prescribing fluids. We should stop any nephrotoxic drugs. So if you know that the kidneys are completely butchered because they're using ibuprofens left and right, you should probably tell them to stop the ibuprofen, and you should stop the ibuprofen. Same reason for if someone is being treated for, let's say, biliary sepsis and they're on amoxicillin, metronidazole, and gentamicin, and you notice that the kidney function is it's correlating with the starting of the gentamicin, then you have to confirm that, or you have to have the suspicion that the gentamicin is becoming too nephrotoxic for them, and you should stop it. You should also treat any electrolyte disbalance. So not every single hyperkalemic patient needs dialysis. And so you should always try to treat them with the hyperkalemia protocols of the insulin, the glucose, or the razzmatazz basically involved with treating that. I've put query consider loop diuretics, and it's very, I think you should consider it, but you shouldn't consider it, because usually in actual practice, you wouldn't consider it unless someone was significantly fluid overloaded. And you would only use it if they're significantly fluid overloaded to try and artificially boost the urine output. So that's why you could consider it, but you'd only have to consider it in a very small population of patients with significant fluid overload. And as I said, in AKI2, AKI3, you should start considering referring to a nephrologist to see the patient, to then assess whether they can actually take fluids, or what to do next. And then dialysis will be the last resort really for a lot of these patients when they're not responding to medical treatments, and they have a lot of complications as well, such as hyperkalemia, pulmonary edema, acidosis, and also uremia as well. That was AKI. Does anyone have any further questions about AKI before we continue, or would anyone would everyone like a 5-minute break or anything like that? I don't know. Nisag, is that okay if we take a break, if people would like a break, or should we just continue?
It's up to you. If people want a break, then yeah, we can take a quick break. But if everyone's happy to continue, and if you're happy to continue,
I would say we keep pressing forward.
Yeah.
Just so you guys you can grasp all of the theory really quickly.
yeah, then the consensus is to continue in the chat as well.
There's a question saying, when do you consider renal replacement therapy? So by renal replacement, do you mean like a transplant, or do you mean artificial renal replacement in the form of dialysis? So if it's in renal transplant, that's something that's actually probably beyond my pay grade, if I'm being honest. But in general, you usually keep it to renal dialysis, and they probably need dialysis. I mean, I know a few patients unfortunately may need to come in every day for renal dialysis. Some people may need to come every 2 weeks. Some may have to have it on at night, just to maintain the function of their kidneys, depending on the stage. But I would say renal transplant would probably be a very, 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 very last resort, if dialysis literally couldn't work. But then you'd have the problem of one kidney not functioning, or you'd only have one kidney functioning, and that would once again be quite problematic, and you'd need a nephrology opinion. How do you decide when diuretics are appropriate to continue start since they're nephrotoxic? Well, not every single diuretic is nephrotoxic, but you're very right in the sense that they are nephrotoxic. I would say that would be on specialist opinion firstly, and then secondly, if you could quite clearly see that this patient is, they've got pitting edema, they've got dyspnea, they've got bilateral pleural effusion, and they've got a lot of complications now of the kidney failure. That would probably be a good time to give them some furosemide, because it's not going to harm them. And in general, something that is probably worthwhile noting for all of you, if your creatinine and eGFR does drop, furosemide is actually a very, very safe option for trying to artificially promote urine output. So I would say those would be the scenarios where you could consider diuretics. Is that okay with everyone? Does anyone have any other further questions before we continue? Awesome. So we've done AKI, so we've done the acute conditions. So let's now talk about the chronic conditions. So we're going to start off with a bit of a case study, and I'm going to open the floor to you guys to suggest what you think is going on, basically. So a 57-year-old gentleman with a past medical history of type 2 diabetes and hypertension presents to his GP with fatigue and weight gain over 4.5 kilograms over the last 3 months. On examination, there is bilateral pitting peripheral edema, so on his legs, and he's got cotton wool patches when you shine the fundoscopy light into his eyes as well. His observations are normal, except for his blood pressure, which is 158/92. Once again, it's not new to us. So what do you think is going on here? Okay, yeah, I'm liking everyone's thought processes here. So we've got a lot of diabetic retinopathies, got diabetic nephropathy, have uncontrolled diabetes, all right. None of you are wrong here. But unfortunately, what we have here is sounding a lot like, firstly, kidney disease, because there's edema. Okay, someone's put autonomic dysfunction, someone has put CKD, and that is exactly what's going on. So we've got kidney dysfunction, and we have got chronic kidney disease happening. And this is a textbook presentation of fatigue, weight gain. What can someone tell me why they're gaining weight? Yeah, exactly. Fluid retention. They're overloaded. And can someone tell me what the best? This is actually a PSA, prescribing safety assessment question. If we were to give furosemide in this patient, how would we know that the furosemide is working well? Can someone also answer that, please? Okay, urine output, lots of urine outputs, a few weight losses. Yeah, so the only way we'd find out whether the furosemide is working would actually be via weight loss. So if anyone put weight loss, it is indeed weight loss. Urine output is good, and I would tend to agree with you, but anything can cause artificial urine output. Lots of fluids IV can also cause a solid urine output. So we'd really need them to continuously start losing weight for us to know that the furosemide is working. So as I mentioned, we've got a lot of CKD going on in this 57-year-old gentleman. And what we've got going on here is you've got the weight gain. So that's suggesting the overload of the fluid. You've got the fatigue. Why? Can someone tell me why fatigue? Of all of the symptoms, why fatigue? Yeah, exactly. You've got anemia going on. Can someone tell me what type of anemia is going on here? Is it microcytic? Is it normocytic, or is it macrocytic? Yeah, you guys know it. So exactly, it is normocytic, and it is indeed anemia of chronic diseases. So yeah, great stuff, guys. So that's what's going on. There's a lot going on here. I'm going to talk about all the fatigue, the weight gain, and all those things in the following slides. But also, he's got type 2 diabetes. He's hypertensive as well. So you have to think that there's also a lot of diabetic nephropathy as well associated with this, or that would be associated with those types of comorbidities. So that's what's going on. In terms of sorry, can everyone see? I just lost my screen there. So with chronic kidney disease, you have 5 stages rather than 3. And really, what you'll see in the following slides that 5 stages is actually 6 stages. I'll explain why in a second. But CKD often goes unrecognized until it's well advanced. So by well advanced, I'm talking stage 3, basically. It affects around 10% of people worldwide. You're thinking that's quite a large number, and it is. But that's because we've got such a massive rise of conditions such as diabetes and hypertension now in every single corner of the world. So that all attributes to it. Other causes for CKD are also chronic pyelonephritis as well. So it's an infective cause, and also you can have genetic causes such as polycystic kidney disease, both adult form and also the pediatric form as well. Pathophysiology, it is highly dependent on the cause, because if you've got diabetes, then you'll have a lot of glycosylation and all of the glomerular membrane, the glomerular membrane effusion and all those crescents and things like that going on pathologically. But in general, you would have an increase in intraglomerular pressure. You would have an increase in glomerular permeability, which would then explain a lot of symptoms. And all of this would lead to renal scarring. And with renal scarring, you'd have a lot of fibrosis, and inevitably you would end up with progressive loss of function. So you'd start off with, your kidneys working at let's say 90%, all the way down to your kidneys working at less than 15%. So that is the big variety of the stages. You can have more than 90% for stage 1, and then you can have, CKD stage 5, which is end stage kidney disease, and it's basically palliative, unfortunately, and that would be less than 15. Your eGFR would be less than 15. Risk factors: diabetes, hypertension. This time, age above 50 years old. Obesity, along with smoking as well. And unfortunately, some ethnicities have a higher predisposition to CKD. So people of Hispanic origin and also people who are Black may have additional risk factors for developing CKD. Positive family history of CKD is also suggestive of a CKD diagnosis if you're male. And as I mentioned before, if you have, or if you've had childhood kidney disease, and also adult kidney disease or adult polycystic kidney disease as well, they be open to developing CKD. These are the stages. I said there's really 6 stages because 3 is A and B. So stage 1 of kidney diseases, eGFR of 90, stage 2, 1689, and you guys can definitely read what's going on here, and you can also see from the image below the eGFR section that the amount of kidney damage that is happening progressively over time is getting bigger and bigger. Some of you clever clogs might have figured out that there's no creatinine involved here. Can someone tell me why we're not using creatinine? Just have a guess, guys. No guess is a bad guess. Okay, we've got one saying could be an acute phase protein. Yeah, exactly. Yusuf has very quickly pointed out that creatinine is actually dependent on muscle mass. So serum creatinine may not actually provide an accurate estimate of renal function due to differences in muscle. And as a result, for this reason, that's why we have eGFR as a form. And another thing that might also affect results would be, for example, if someone is pregnant, the eGFR might be deranged or it might be different. Muscle mass, obviously, as you've mentioned, and also, for example, bodybuilders that eat a lot of meat have, I mean, if you eat a lot of red meat prior to having the sample being taken, your eGFR would be skewed as well. It might not be as accurate. Okay, someone's saying, why is it used for AKI then? Because that's a good question, actually. The reason why creatinine is, I think, used during AKI and not in CKD is probably because creatinine is a very, very acute way of finding out, I think, kidney clearance, in my opinion. So obviously you guys know about inulin and all those other kind of physiological tests that we can use to figure out kidney function, and creatinine is the most accurate way of figuring out kidney function. If the creatinine is high, then you know that that you're dehydrated and the kidneys aren't functioning. Whereas in chronic disease, it's hard to figure out whether it's an accurate parameter for diagnosis, if that makes sense. So yeah, moving on. these are the 5 stages. How can CKD present? So CKD can present with fatigue due to the anemia aspect, edema because of the overflow or the overload and the overflow of lots of fluids, restless legs. Restless legs is really to do with the diabetic aspect of the CKD, dyspnea and orthopnea as well. So we're mainly dealing with the fluid part of things here. And then foamy or cola-colored urine, osteomalacia and osteoporosis as well. And then you can also have nausea without vomiting, pruritus and anorexia as well. Why the fatigue? So as you guys very correctly mentioned, it's due to the anemia of chronic disease. So the anemia will cause reduced EPO levels, and the reduced EPO levels are the most significant. They're the most significant factor in the fatigue symptom. And you can also have reduced erythropoiesis due to the uremia toxicity. You'd obviously have reduced absorption of iron as well if your kidneys are not functioning as well as possible. The uremia would also cause the anorexia and the nausea as well. Another thing that I've not mentioned as well, you'd obviously have a lot of blood loss due to fragility of the red blood cells, and you'd also probably have poor platelet function as well. So how would we treat the fatigue in this? So the first thing you do, you'd have to try and get the hemoglobin up. So you guys are all clever, so you know what the normal ranges of the hemoglobin are for both male and female. But in general, you should try and have hemoglobin higher than 10 grams per deciliter. I know in the elderly, it can sometimes flirt between 90 and 100 and sometimes even lower, but it's fine if it's stable and if they're not symptomatic. If they're symptomatic, then that's a cause for concern and it should be elevated as soon as possible. You can also have, well, we've got a question. So would you give folic acid? No, you wouldn't give folic acid in this situation because can someone tell, or can someone try to explain why you wouldn't give the folic acid? The folic acid isn't really indicated because there's no signs of folic acid deficiency. This is purely because of the EPO being reduced, and you would probably find a more blood film of all of the other ferritin, folate, and all of those types of values. So the main thing that we're dealing with here is the EPO, and as a result, you would need to have erythropoiesis stimulating agents. So this is basically ESA, and potentially if you're on hemodialysis, that might not be appropriate for you, and you would need to have IV iron, parenteral, as someone has put in the chat, if you're on hemodialysis. And then also you may need EPO as a last resort, or as a third line option for getting the hemoglobin up. Why the edema? So I think we've all discussed this, why the edema. But if you guys would like to use the chat, you're more than welcome to. Why the osteomalacia or the osteoporosis? So this is why, or this is because of 1-alpha hydroxylation usually occurring in the kidneys, and if they're damaged, naturally you would have low vitamin D. And if you have low vitamin D, it goes hand in hand that you'd have low calcium. And if you've got the low calcium, then your body would try and compensate in such a way that it would try to increase it. And the only way the body knows how to try to increase our calcium levels when they're low is by having the parathyroid gland work overtime, basically. And as a result, you would have hyperparathyroidism. Can someone tell me whether this hyperparathyroidism would be primary or secondary? Exactly, yeah, secondary. It would have to be secondary because it's in response to the body rather than primary pathology. And so when the parathyroid gland starts working, obviously it tries to rectify the low calcium, but what it does is it actually starts causing high phosphate levels. And high phosphate levels really need to be countered because they can cause some problems further down the line. And the way that we try to cut down on those is the first thing that we try to do for pretty much every single condition that's systemic is we try to have some sort of dietary control, and we try to modify our diet. So we try to limit phosphate intake. And the second way we would try to combat this would be to use phosphate binders. So there's a few phosphate binders out there, but the one that I think, or the only one that I really know, and I think that you guys should probably know, is a drug called sevelamer. And basically the phosphate binders will bind to the dietary phosphate, and it will prevent its absorption. And it also has quite a good profile because it reduces uric acid levels as well. So you really kind of cut down on the potential effect of uremia taking place as well. Third line would be vitamin D substitutes or artificial causes or artificial ways of supplementing vitamin D. So you have calcitriol, alpha calcidiol as well. And in some cases, parathyroidectomy can also help as well. This is the osteomalacia. We have a question, well, there's a question in the chat, and also there's also a question here as well. So a 62-year-old lady with stage 3A CKD visits her GP to discuss the results of an annual EGFR test. For the last 3 years, her EGFR has been 59, 51, and 35 respectively. What do you think is the most appropriate step in her management plan? Okay, so a lot of people are saying refer to a nephrologist. A couple of people are saying prescribe an ACE inhibitor. All good suggestions, to be honest. But unfortunately, the correct answer here is refer to a nephrologist. And that is all in line with NICE guidelines. So the correct answer, just to reiterate once again, is you would have to refer to a nephrologist. And you'd have to refer to a neurologist because the NICE guidelines explicitly state that if the EGFR falls below 30 or progressively more than 15 in a year, you have to refer to a nephrologist. And in general, the NICE guidelines for any sort of kind of nephrology special or specialist opinion are as the following. So a urinary ACR, which we're going to discuss later on, of 17 millimoles or more unless proteinuria is known to be associated with the DM is being managed, should be referred. ACR of more than 30 with hematuria after exclusion of UTI and also renal colic has to be referred. Uncontrollable hypertension, and then also rare causes of CKD, suspected renal artery stenosis, and also any complication of CKD. So that would be any of these, any of the symptoms that I mentioned at the start. So as I said, we were going to discuss ACR. So you might be thinking, what is ACR? And I'm going to get into that in a little bit. But I think what's important is you'd have proteinuria. So you'd have frothy and foamy urine. Also potentially, colour-colored urine as well. And the reason why proteinuria is really important and it's something significant is because it's an important marker of the CKD, especially for the diabetic nephropathy side of things. And the way that we try to investigate this is by performing a ACR. So an ACR is, ACR is actually by definition albumin creatinine ratio. It's preferred to PCR, not PCR for COVID or anything like that, but protein creatinine ratio. And you might be thinking, how do you perform an ACR? So the way that you perform an ACR is by collecting a spot sample. So a spot sample basically avoids the need to collect urine over a 24-hour period. You just do it once, and that's the spot. It should be a first thing in the morning type specimen, and not during the day or at nighttime. And in terms of analyzing it, if the ACR is between 3 and 70, it needs to be verified, and by being verified, it needs to be repeated subsequently in the next morning to confirm that there is proteinuria. If there's more than 70 milligrams of millimole, no repeat is needed because it's very bundle basically. So this is a small table. It's been lifted from Past Medicine. The ACR is 30, and between 30 and 70. Then you can see what the urinary protein excretion is like per gram over 24 hours. In the next slide, we're going to discuss more about the interpretation. So if the ACR is more than 3 milligrams per millimole or more, it is confirmed clinically important proteinuria and is highly suggestive of diabetic nephropathy and also chronic kidney disease. Now, NICE guidelines once again say that if the urinary ACR is more than 70, and unless we know that proteinuria is already associated with the diabetes and is being managed, you need to refer once again to a nephrologist. And once again, I'm repeating myself here, but anything above 30 with hematuria after exclusion of UTI and renal colic needs to be referred to a nephrologist. So basically, it might seem to you guys you just always have to refer to a nephrologist, and that's not a bad option, to be honest. But you should really tend to consider referral to a kidney doctor when the ACR is between 3 and 29. And especially if someone has concomitant symptoms such as persistent hematuria, and they also have declining eGFR and cardiovascular diseases as well. This was ACR. This is a very nice diagram. It doesn't always make a lot of sense. It definitely didn't make sense for me as well. But this is basically, this essentially was how frequent you should probably monitor eGFR in terms of number of times per year with the cumulative risk of someone developing CKD. So if on the left, you can see all of the different stages of the CKD staging system. And then on the y-axis here, oh, sorry, this will be our x and this will be our y. On the y here, you've got the ACR ratio. And you can see that if someone's eGFR is quite good and their albumin creatinine ratio is also below 3, then it's highly likely they don't have CKD. They might not need monitoring as frequently as someone, for example, with eGFR less than 15 and ACR of more than 30. They would have a very, very high likelihood, if not absolute probability, that they have CKD and they need to have regular monitoring. So those are all of the symptoms and how to manage them and how to interpret them. We should also try to manage the systemic diseases as well as we can. So we should try to manage the hypertension. It's very difficult to manage it in people with uncontrollable kidney disease sometimes. So you would have, naturally you would have someone on an ACE inhibitor. Once again, any drug ending in pril, and then you'd also have an ARB going alongside it. These days, they don't tend to make combinations of ACE and ARBs. They're usually separate. You'd have to have 2 different tablets. But yeah, you need a sartan, you need a pril, and you also might need a renin-angiotensin system blocker, or for example, you might need a renin agonist as well, just to control the whole hemodynamics of things and the equilibrium as well. As I said, furosemide is always something that you should consider, especially when the eGFR is less than 45 mils, and when there's significant, overload as well, as I mentioned earlier, just because it can artificially promote urine output, and it can tend to significantly improve the clinical picture of the patient. But anyone on CKD, you'll see that there'll be a prime textbook example of polypharmacy. They'll have a lot of things that they have to take to try and control it. The next thing is, we have to be a bit more effective with managing the nephropathy. So the way that you try to manage the nephropathy is by having an effective screening program. And by effective screening program, each patient should ideally be screened annually using ACR, and including that criteria would also be having regular fundoscopy, and also probably monitoring their HbA1cs as well. And with everything, as I said, you try to modify the diet. So you'd have to encourage the patient and also advise the patient to try and restrict the dietary protein intake. You try to control their blood pressure as much as you can. You try to aim for the BP to be less than 130 systolic and 80 diastolic. And then you'd have to also control the dyslipidemia with a form of statin as well. And a lot of recent trials are actually showing that there's a lot of benefit if you have, there's a lot of benefit for combinations. Sorry, not combinations. There's a lot of benefit for the individual if they have an ACE inhibitor and an angiotensin 2 receptor blocker, so sartan basically running concomitantly as well. So they do improve outcomes. And there's also another pearl for all of you listening. There's also another trial, I think, going on that SGLT2 inhibitors as well are very, very potent at trying to control CKD. And also SGLT2 inhibitors also being used right now for COVID trials as well to try and combat the fluid overload of all of the pleural effusions as well. So we're kind of coming up to the end now. So I only have 2 questions left now. So hopefully you guys have got a really good picture of what's going on with acute kidney disease and also CKD. And question 4 is, sorry, we've got a question. So what stages of CKD require dialysis? So that's a very subjective question, and that's highly dependent on the clinical picture. So if the EGFR, for example, is really in the dumps, and they've started developing symptoms of uremia, overload, any diuretic is not working and things like that, then they have to be a candidate for dialysis, because dialysis would be a life-saving intervention, basically. No, it's not just symptomatic relief. It's more controlling or trying to get a better control to stop the inevitable rapid progression if you do not control these things. It's a bit like Parkinson's. You can't reverse Parkinson's, but you can control it to a level that you can function. And with chronic kidney disease, more often than not, if it's uncontrollable, you will end up in end-stage kidney disease where your kidneys are butchered and you struggle with day-to-day life, unfortunately. And once you start dialysis, this is a long-term thing, or it can be a one-off treatment for some people. It can be a one-off treatment in cases of intoxication. So, for example, paracetamol overdose or any other type of overdose can be, but more often than not, it's usually a long-term. It's a long-term activity, unfortunately, but the frequency of it can vary depending on how well you control your symptoms. So you can start off with, going to dialysis machines or the nephrology unit of every hospital, maybe twice a week, and then you might find that once you start controlling the systemic diseases better, you can maybe frequent the hospital less if it's controllable, if that makes sense. Yeah, back to the question. So you have a 65-year-old man with type 2 diabetes who presents to his GP for an annual routine diabetic check. As part of the routine checkup, he needs to be tested for diabetic nephropathy. He denies having any signs and symptoms of chronic kidney disease, and his prior urine tests have been normal, and his diabetes is when well controlled by the metformin. So how best should the patient be screened for the diabetic nephropathy? Is it option 1, where you measure the protein creatinine ratio, PCR, on a spot urine sample? If the results are abnormal, you repeat it first thing in the morning, or do we do the ACR way? And if it's abnormal, we repeat it again. Or do we just perform a urine dipstick test? Or do we take bloods and monitor the HbA1c? So what do you guys think? I'll just create a poll. Make it a bit easier for everyone. Good. A lot of people have answered, and I'm glad everyone has been listening, because everyone has pretty much put B. So that's good, and that's very right. You would have to measure the ACR on a spot urine sample first, and if it's between 3 and 70 milligrams per deciliter, then you'd have to repeat it. And once again, if it's repeated and it's elevated, then that is confirmed for proteinuria, and as a result, the diabetic nephropathy and the CKD. I mean, you would be performing you'd be taking regular bloods and you'd be monitoring the HbA1c as well in general. So that's not a wrong answer, but ideally you'd have to do the albumin creatinine ratio first, and then repeat it to verify it, and then you have to take it from there. That's question 4. And the final question is, what are the differences between acute kidney injury versus chronic kidney disease? So I'm going to leave this, I'm going to leave it open to all of you to put in the chat box. What do you guys think are the other differences? Yeah, I mean, everyone has pretty much hit the hammer on the head. So AKI is more often than not reversible. I can't actually reproduce the amount of AKIs that progress to CKD, but I know there's obviously a risk factor for having, or if you've had previous AKIs, you are at risk of having CKDs. And people with CKD can also have AKI, if that makes sense. But also, yeah, the AKI is reversible, as I just said. The kidneys, exactly. I'm glad someone pointed out the kidneys. So usually you would have a bit of a change in the appearance of the kidneys, and you'd probably have to do an ultrasound to actually assess the kidneys. You'd probably expect for them to be reasonably shriveled up and definitely atrophic in chronic kidney disease, but in acute kidney disease, that they would actually look relatively normal, and it would be more based on the glomerulus or the glomerular disease or the postrenal aspect of things as well. Symptoms as well. Yeah, urine output acutely in AKI, and there's obviously creatinine, which is a more acute marker of how the kidneys are filtering fluids. Someone has said that there's 3 stages in AKI and 5 stages in chronic kidney disease. So pretty much everyone is right, and I think you've all been paying attention as well. So yeah, that's really good to hear and see as well. So thank you very much. I think this is the end of my lecture now, but hopefully this was